Hello, everyone. Welcome to the Crisis Residential Association's webinar, A Safe Place for Help, Understanding the Crisis Residential Model. My name is Pete Hilen, and I will be serving as your host today. There are a few housekeeping items that we should go over. So one of them is the Zoom platform allows for people to submit questions through the Q&A portal or send chat to the host or presenters. Everyone will be muted for the webinar. Number two is questions will be answered at the conclusion of the webinar. Please submit your questions through the Q&A portal located in the controls of the Zoom site. Today's webinar will be recorded. Recordings are available for all registered attendees. And lastly, you will receive a survey via email at the conclusion of this webinar. We appreciate your feedback as it helps us and inform us for future webinars and offerings. So those are a few housekeeping items just to keep in mind. And now it is my great pleasure to introduce our presenters, Heather Honaker and Travis Atkinson. Heather is the president of the Crisis Residential Association. Heather is a nationally certified behavioral health professional experienced in operationalizing the mission and values of community-based services. She's a proven leader that's achieved results through strategic planning, relationship building with extensive knowledge of crisis intervention and stabilization best practices that are grounded in ethics, integrity, collaboration, and enthusiasm. So it's great to have Heather as a part of this presentation. And Travis Atkinson has worked in the behavioral health services for the past 20 years as a clinician, trainer, supervisor, advocate, and consultant. He has presented on SAMHSA panels around crisis systems and crisis bed registries, researched best practices in emergency behavioral health care, and spoken at national behavioral health conferences on functional crisis systems and behavioral health workforce challenges. Since 2015, he has worked at TBD Solutions, and he was instrumental in authoring the Crisis Residential Best Practices Handbooks in 2018. He is the past president of the Crisis Residential Association. So it's my great pleasure to introduce those two. And lastly, I want to say, this week is as part of this seminar. This week is Crisis Residential Week, and we are honoring and celebrating all the hard work and dedication that Crisis Residential workers and associations and companies have put forth. So really do appreciate everyone's participation in this, and hope you guys are celebrating this wonderful week for Crisis Residential. So with that, I will turn it over to Travis and Heather.
Thank you so much, Pete. So I want to start off talking about this gentleman. For some of you who grew up in the 90s, this person might bring you some nostalgia. This is Mark Summers. And I remember Mark Summers because he was the host of this very famous game show called Double Dare. And what would happen in Double Dare is your family would get asked a question. If you didn't know the answer, but you thought maybe the other people also didn't know the answer, then you'd say dare, and then they could say double dare. And if you got to the double dare, you would get the physical challenge, and then that's the part of the show that most people look forward to. And I just remember Mark's charisma as he hosted this game show with families and kind of got them to do some wacky and zany things. Now later on, Mark Summers also hosted this show called What Would You Do? And What Would You Do was based on this premise of what would you do in a certain situation. So they would start by filming a few seconds of a person who's asked a question or asked to do something, and then they would cut away and they would poll the live audience and say, what would you do? And then they would show the rest of the video and say, this is actually what that person did when they had to make this decision, touching a gross, something slimy, or petting a snake or something like that. And I thought that this question was appropriate for us here today because we think about crisis services sometimes in a very conceptual space or in a theoretical space. But the truth is, what really matters is being able to answer that question, what would you do in a situation that was urgent or dire? And how would you offer other people help in a situation like that, in a crisis? So what we'd like everybody to do on the call, we're so glad you're here, is to go ahead and get your phone out or go to the website that is listed there and type in that number. We'd love for you to answer this question, which is that if your best friend was in a crisis tomorrow that required ongoing treatment, where would you encourage them to go for help in your community? What would be that option that you would think of? Some people think automatically, oh, I would send them, to a psychiatric hospital. That's what is available in my community. Maybe you have family members or friends who have gone there, who have had good experiences. Maybe the options aren't very obvious. Maybe there's kind of a dearth or a gap in crisis services in your community. And if you don't know, that's okay too. I've certainly felt that way in moments of crisis for my colleagues or family members as I go, gosh, what is the best option? What would be there? Now, I'm encouraged by what y'all are how y'all are responding. And maybe, I don't know, Heather, maybe we have like a saturated audience already that is a little bit familiar with what we're going to talk about today. But that's good. And what what we what we hope to share today is that there are options available. There are models that have been designed for people who are in crisis that can have these transformational impacts and sometimes far exceed what's currently available in our community. There's this great quote by Pearl S. Buck. It says, "The test of a civilization is in the way that it cares for its helpless members." And so if we consider people with disabilities, with chronic illness, with mental illness, with addiction issues as some of those most helpless members, then it's really important that we get these crisis services right. So with that, I want to share a story with you before I hand it over to Heather. And it's the story of something called Soteria. This is the Soteria House, and in 1971, the National Institute for Mental Health funded a research experiment where people with their first ever symptoms of a psychotic disorder were randomly assigned to treatment in a psychiatric hospital or in a house, this house right here, which is in San Jose, California. Now, the home wasn't staffed with nurses and psychologists. As a matter of fact, Dr. Lauren Mosier, who's the principal investigator, made sure that everyone who worked there had no prior history of working in psychiatric treatment, so as not to bring bias or unhelpful clinical approaches into the work. It seems kind of weird, but I think he had a point to what he was doing. Instead, he hired caring, empathic people with a high distress tolerance to embrace the power of simply being with people as they journeyed through their psychotic episode. Now, Mosier rarely used medications for treatment, only about 12% of the time, and yet his outcomes for people who received care in the crisis homes were better than the control group who received treatment at the hospital. So Mosier's focus on unconventional solutions allowed him to act bravely in the interest of his patients. This angered and upset a lot of people, but his work has led to the development of hundreds and hundreds of crisis residential programs in the United States. So what Mosier did after this Soteria study is he moved to the DC area. He opened a program called Woodley House. He opened another crisis residential program in Maryland, and they started to serve people with depression and anxiety as well as psychosis, and were able to demonstrate these amazing results. And Heather gets to talk a little bit about what those ideal features are of these programs as we start to unpack this model and understand why it's so important in our crisis continuum.
So when we think about what makes a crisis residential program that and what separates it from other services in crisis, particularly those that are facility based, we think about the length of stay. This ranges across the country, but lengths of stay are typically 7 to 14 days. These programs range in size from 6 to 16 beds. They operate in unlocked facilities in a home or in a home-like setting. We've seen them in communities where you can't tell your neighbor's house from the crisis residential program. They function as both a diversion from hospitalization or a step down. So sometimes we're able to catch folks on the front end, so they never actually have to go to the inpatient hospital. And then sometimes when folks are hospitalized, they still need a little bit more time to stabilize, get connected to resources before going back into the community. And this program can serve that purpose as well. Another feature, this model does have clinical staffing, your typical set of staff, but they also include peer support specialists or recovery coaches who are people with lived experience in the program. And we're calling this a crisis residential program, but we've heard it called all sorts of things across the country. Sometimes crisis stabilization unit, community crisis stabilization, acute crisis unit, crisis respite. I'm located in Virginia, where we call it a residential crisis stabilization unit. So we smush some of those together. But all of those names kind of mean that same thing, that crisis residential facility.
And we'd love to hear in the chat if y'all have a program like the one that Heather just described. What do you call it and where are you located? So feel free to use the chat to just share some of those names. One of the hardest things as we talk at a national level about crisis services is getting the names right. We have so many different names for mobile crisis teams. We have different names for 23-hour units or access centers, and we have different names for crisis residential programs. So go ahead and type that into the chat. We'd love to hear what your state calls them or what your community calls that level of care.
When a person is in crisis, they may have lots of different options, or they may not. It depends on what your community has. So this diagram that you're seeing shows some different routes. When a person is in crisis, they could call a crisis hotline, then be assessed by a mobile crisis, and then access a crisis residential treatment facility or a psych hospital. They could also go to a 23-hour observation facility to be assessed and then admitted. Same for behavioral health urgent care. We know there are communities that the local community mental health center serves as an access center, and they conduct assessments, and they're kind of that gatekeeper for admission. And then we also have emergency departments. We know that a lot of people are heading to the emergency department. They're not really sure what they need, and they're hoping to find the answer there. Sometimes they're diverted to psych inpatient. Occasionally, they are routed from there to a crisis residential treatment. And then if communities just don't have any other options, sometimes maybe it's even back to their community mental health center. This option up here on the left corner, peer respite facilities are also an option, and we're going to talk a little bit more about what those are in a couple of slides.
Heather, as we've learned about the national guidelines for behavioral health crisis care that were published a few years ago by SAMHSA, what feels like one of the misunderstandings that people have maybe about this crisis residential level of care when it comes to how you can access it or what steps you should take before you access it?
Sure, that it's maybe more of a less acute or a post-crisis option, when really crisis residential facilities are equipped to handle lots of different challenges that folks have. And many of them even take quasi-directed missions. They have to have that assessment first to make sure that it's an appropriate level of care. But crisis residential facilities certainly fall in line with that crisis continuum and fit into, if we're going to put it into a bucket, the safe place for help. So I just mentioned several crisis services, and this is kind of a look at approximately how many there are across the country. So for call centers, there are about 800, with 200 of those being 988 call centers. 600 crisis residential facilities. That number always excites me, and I want it to be higher. 500 mobile crisis teams, 350 23-hour crisis stabilization facilities. That number, I think, is growing as that gains traction across the country. And then peer respites, there are only 60 of them scattered across the country.
So we want to talk a little bit more about crisis residential programs' role in the crisis continuum, why it's essential that every community of a substantial size has a crisis residential program so that its members or that its citizens have access to this level of care. First of all, it provides a recovery-oriented and person-centered approach to treatment. There is a sense um, of equality between the treatment team members, and the voices of the people who work in the programs are valued, and everybody has an important role to play in supporting people. But it doesn't take a medical model that says we're going to focus on your diagnosis alone, and then once things aren't bad anymore, then we'll discharge you. It takes a very person-centered approach, and it recognizes that it may have taken days, weeks, or even months for an individual to escalate to the level of crisis that they're experiencing at the moment that they come into the crisis residential program. And so it's really ambitious to expect that in 24 hours, everything's going to be better, or that person's going to be ready to be served in an outpatient setting. The second is that people in crisis who are suicidal and in need of connection and empathy can thrive in such an environment. We in the United States take a very risk-based approach to our behavioral health care. And I can understand where it comes from. Probably it starts with concerns about risk and safety and litigation, but it's completely the opposite approach that is taken in other parts of the country, such as in Europe. We have to believe that if we create an environment that is healing and therapeutic, that people are going to respond favorably in those settings. In some places in Europe, even in the psychiatric hospitals, they're using glassware. They're allowing the patients to have access to knives, and we would many of our systems would shudder at that possibility, but the folks in these countries wouldn't do that if they didn't have good results in allowing people to have this agency and choice, which we believe is an essential component of these services. That's why they're unlocked. In most states, this is an unlocked level of care because it needs to feel like a home. The third point is that when crisis takes a 23-hour or less approach, which we might call a fast food approach, people end up needing help again and again. And even if you extend your observation unit to 48 hours or to 72 hours, you're not running support groups in that setting. You're not getting the chance to build meaningful relationships, professional relationships in a therapeutic setting. A lot of times it's for observations. It's to see how medications are working, and you miss out on this opportunity to have this social reconnecting or this healing that can happen in those programs. It also, let's remember, if we don't have access to a multi-day level of care in a therapeutic environment, we're placing a lot of pressure on our outpatient system to pick up the pieces or to take the next step immediately after that person leaves that very short level of care. And then lastly, well, I guess I kind of said this one already, but you want to have these options available because sometimes a therapist is not prepared to take someone who was just in crisis 24 hours ago. It's really helpful when the crisis system that is serving the individual can also be responsible for some follow-up support in the weeks after the crisis. That's actually been shown to help reduce readmissions and increase hopefulness in individuals. But it's essential that people have choices. And what these programs have also shown in different states like California and Michigan is that the admission criteria for a psychiatric hospital and a crisis residential program can be almost identical. And it is just a matter of imminent threat to harm or others, and the ability to contract for safety. And so when we say, oh, that person can't go to that program because they're meeting criteria for inpatient psychiatric hospitalization, At some point, when we started having private inpatient psychiatric hospitals, we created the criteria for that, right? So we can also say this person might meet that criteria, but they can thrive in a different environment.
Travis, I want to share, as you were talking, just a couple of memories from times working in crisis residential. And one of my favorite images is seeing people like in the kitchen, hanging out around the island, talking to one another, talking to people that they would have never otherwise met, and just having a good time and connecting human to human, sharing a snack. That in itself, like that's part of that milieu therapy that makes this approach so special. Another thing that came to mind was how many people would come in at admission time and automatically hand over their belt and shoelaces.
Hmm.
And it's that kind of program, right? You get to keep those. We want to maintain your dignity. We respect you. We trust you. You get to keep those while you're here.
Thank you, Heather, for sharing that. One of the most compelling aspects of these services is the research that's behind it. So those Soteria studies that I talked to you about from the early 70s, that was the beginning. That was where we first saw these controlled trials where people were randomly assigned, or we saw intense focus and research done on these services. And what's amazing is that crisis residential programs are one of the most highly or frequently researched levels of the crisis continuum. And if you don't know about the triple aim was designed by the Institute for Healthcare Improvement, which is a three-pronged approach that focuses on better outcomes, lower cost, and higher client satisfaction. And fortunately, crisis residential programs meet the triple aim. They, in research studies, have higher client satisfaction than their inpatient psychiatric hospital counterparts. They show as good or better effectiveness at reducing symptoms like depression and anxiety and psychosis while increasing hopefulness. A program that Pete used to work at, as a matter of fact, at Telecare, one of the largest crisis residential providers in the country, was able to demonstrate through a hope scale that the services have a meaningful impact on a person's recovery journey. And then lastly, they're lower cost. When you don't have to have, let's say, 24-hour nursing, or you don't have to have security on site, you don't have to have all of the other expenses that come along with a hospital, you can charge a lower rate, or you can operate this facility at usually about 60 to 70% of an inpatient stay. That the per diem there is lower, and you can still get some of the same outcomes. I know we're not talking about finance right now necessarily, although we are on that point here, but I have to share this way of thinking. If you have ever been a case manager or a clinician, and you knew one of your clients was in the hospital, and maybe they were isolated, or they had just come in after a suicide attempt, and they didn't have a strong social network. What often happens in a psychiatric hospital is that the doctor, the psychiatrist, says, if there's not support for them over the weekend, then I don't want them to go home. So I'm going to keep them here through the weekend. Now, my experience tells me that inpatient psychiatric hospital stays can cost about $1,000 a day. So if that's the case, then Friday night, Saturday night, and Sunday night, that's a $3,000 addition to the length of stay that they've already had, when they could transition to a crisis residential program for Friday, Saturday, and Sunday. You could save 30% of your costs, and you're giving the individual more freedom as they get ready to transition home. It just makes sense. And if crisis residential programs can work closely with the psychiatric hospitals, or work closely with the doctors at the emergency department, you can see a dramatic decrease in these lengths of stay, while giving them kind of an intermediary opportunity to transition back home. So this is my friend Steve Field. Steve is definitely one of the OG, like, godfathers of crisis residential treatment. He's told me on a couple of occasions that he had a chance to visit Soteria when it was operating in the 70s. And in the early 80s, he had a chance to join an organization and later became the executive director of the Progress Foundation, which is based in San Francisco and serves the neighboring counties and provides crisis residential services there. And the story he described to me was that in order to demonstrate the relevance of their program, they would go to San Francisco County Hospital and they'd go to the emergency departments and they'd say, "We know you're overrun with psychiatric patients. We will take anybody you refer to us. No questions asked. Just send the people to us that you want to send to the psych hospital but can't, and we will serve them." And what he showed them, what he demonstrated in one admission after the other, was that they were able to manage this risk that was previously done in a locked setting in a Victorian 2-story home in San Francisco instead. And Steve has just been so passionate about crisis residential services and about advancing these services so that more and more people have access to them. And they've just worked wonders. And Steve has an awesome quote that I heard him say in a talk he gave about 10 years ago. He said, "If you don't have in your county a fully staffed crisis residential treatment program, you are hospitalizing people who don't need to be hospitalized." Remember that question that we asked you at the beginning of this webinar about what would you do? Sometimes what we do is forced by what we can do. And if we don't have access to this level of care, whether it's because it's not available in our county or our insurance doesn't pay for it, then we are left with limited options and options that might not be the best for us or our family members.
So I mentioned peer respite earlier. These are also crisis residential facilities that are often in a neighborhood, in a home. These are definitely the ones that you walk through and you're wondering, like, am I in a treatment facility or is this a bed and breakfast? They're just that homey and welcoming. These are unlocked, voluntary, and non-coercive services. The big difference here is their staffing is non-clinical. They are trauma informed and they're entirely peer operated. So all of the staff running a peer respite facility are people with lived experience. In these types of settings, the guests can maintain their employment. If they need to go to school or do something in the community, they don't have to entirely step away from that to receive care here. The length of stay is determined by the individual who's there. They get to define their crisis, what they need, and how long they need to be at this facility. They don't have someone telling them, oh, your length of stay is up, your insurance has run out, or whatever other reason we might have to push people to discharge at times. That doesn't happen here. You get to decide what you need. And then the operating costs are dependent on the location and the number of guests. And again, there are only about 60 of these across the country, but they are just incredible facilities and they're so beautiful. And we're going to show you some pictures of a peer run respite that's located in North Carolina. See what I mean, right? Like this looks like a bed and breakfast, or maybe even like some of your homes. They're very intentional about hospitality, about making sure that each part of the facility is accessible to the individual. You're encouraged to come in, to put your clothes in the dresser, or to hang it in the closet, and to really like take up the space you need and take what you need from the facility before you go back home or back to your communities. So where does CRA fit into all of this? The Crisis Residential Association is a 501c3 nonprofit organization that exists to support the operational and clinical functions of crisis residential programs around the world. We're very fortunate to get to interact with people who operate these, who share their excitement about it, their challenges, and just people who get it. It feels good to interact with someone else who knows what you're talking about when you say crisis residential. So we do that by offering education. We do webinars like the one you're watching today. We offer support through a listserv. We make sure we're intentional about connecting. We are co-hosting a conference called CrisisCon with the International Council for Helplines in Phoenix. And we make sure that we gather all of our members there to say, hey, like, we also run crisis residential, and that's a really cool thing. And then another big piece is advocacy. We want to make sure people know why it's important to have crisis residential in your community. Travis mentioned that Steve Fields quote that if you don't have one, you're likely over hospitalizing people. It's really great to have this option. And when folks know that this is in your community and available, they feel empowered to use it. And then they have choice in where they're going. And that's just, it's a really great option for people to have.
And I just want to add to that, Heather, that I was working in a community a few years ago, and they were looking at their chart review. They were doing a chart review and looking at those who had been admitted to the psychiatric hospital. And they were really proud because they said, look, we think that 95% of the people who went to the psychiatric hospital belonged there, that this was the right, like this was the right level of care. And the fallacy there is that you think that the ends justify the means, that you're going to look retrospectively at an inpatient admission in a chart review, and you're going to say, okay, they check this box, they check this box, they check this box. This was definitely the right place for them to go. What that doesn't account for is how many of those people could have actually done really well in a lower level of care, in a level of care that wasn't as restrictive, that wasn't as intensive, as expensive. How often could they have done that? And as I'm sure many of you know, the story of crisis care is a story of people and communities being willing to bear more and more risk that was traditionally held by our medical safety net or our first responder safety net, and moving that into a place where people receive a more humane, a more person-centered treatment experience. And so we have to keep those things in mind, that you can't just say, well, everybody who goes to the psych hospital met criteria. Well, everybody, about 3/4 of the people who are referred to the psychiatric hospital could meet criteria for a crisis residential program. So what we have to check ourselves there a little bit as we hold these entities that have a place in our brain with such high regard, when in fact we need to reimagine and revisit the idea that we could help people in a different way.
If you're interested in joining us, we would welcome you to by becoming a Crisis Residential Association member. We offer discounts to the conference, CrisisCon, that I mentioned, access to all of our webinar recordings and slides, and then also access to a national listserv. This has been such a gift to me when I was operating a program, and even now, just to know that, like, I'm not alone in dealing with a crisis residential program. Thinking about times where we've asked, like, hey, what kind of bed sheets do you use at your program? Or how do you manage if someone wants to go out on a pass for a day? It's a really great place just to ask people. There's no day that ever felt the same in crisis residential, and there are always new challenges coming up that my policy and procedure manual knew nothing about, right? And so having a group of people who maybe have been there and done that just felt like such a gift to be able to connect to them. So that's probably my favorite part of our membership, and you can learn more at crisisresidentialassociation.org.
The next webinar that the Crisis Residential Association is hosting is called Culture Eats Strategy for Breakfast, Building and Sustaining a Great Culture in Your Crisis Program. And if you scan that QR code right there, you can register right now. So we'll keep that up there for a minute as we transition into our questions. Because Pete, I think maybe a couple came through the Q&A. Would you like to share those with us?
Yeah, for sure. So we have a few questions that came through. The first question is, do you continue to see peer roles being recognized as a crucial part of the crisis continuum moving forward?
I love that question. And for me, it's an emphatic yes. I'm surprised that I continue to discover communities across the United States that are questioning the utility of peer support specialists and whether they are helpful. For me, it's not a question of whether, it's a question of how. How much are our systems willing to release their grip, or are these disciplines willing to release some of their stranglehold on certain responsibilities so that we can make more and more spaces for peer support specialists. When I operated a crisis residential program in Michigan, they were an essential part of the staffing structure. I couldn't have imagined operating the service without peer support specialists there. And as Heather mentioned in the peer respite model, that is entirely run by people with lived experience. And there's great research behind those services as well as a cost saving means in a community, and also diversion from emergency departments. So I would love to see peer supports just take on more and more of a role. And I was really grateful for all of the service that peer supports provided, because they made an incredible difference in our homes.
Travis, what I would add to that is what we're seeing in communities and even in states is more and more discussion about, well, let's define this role and let's figure out how to lean into this and to bring them into the fold so that we understand and we can keep this going, or we can make this an essential part of our staffing. So I think we're seeing enough of those conversations to like encourage us, or like to help us go, yeah, we see this continuing to be a thing that's pushed and that's talked about as it should be.
Yeah.
Right. The one of the other questions that was posted in the Q&A is, what suggestions would you guys have for starting and funding peer respite centers or crisis res in smaller counties lacking funds to do so?
I have a couple things come to mind. I'll start with crisis residential programs. In many states, there is a Medicaid billing code that's available, and it's H0018. There's a modifier that can be used for substance use residential programs as well under that code. But for states that operate a fee-for-service model, that can be a good place to start. Now, some states like Ohio fund their crisis system through tax levies. And so there's not really much funding that's coming through Medicaid. The crisis provider is receiving a certain amount of money every month or every year to operate the crisis continuum. So that would need to be kind of blended in or built into how other crisis services are provided.
Mm-hmm.
What's important in a rural community, as you think about the risk that it might take to open a facility, I'm not even talking about the people you're serving, but just buying a building, doing the rehab or the retrofitting in order to make it work. There's a lot of financial investment and community investment. You have to address NIMBYism, which stands for not in my backyard. You got to address the skeptics, but you have to show a return on investment. So to get to that funding answer, I think you have to start by saying, who is footing the bill right now for inpatient psychiatric care in our community, that if they could pay for something that was less expensive, they'd be willing to divert some of those dollars in that direction. Or if an entity like a hospital saves a lot of money because they don't have as many people boarding in the emergency department waiting for a crisis bed, would they be willing to send some of those cost savings back to the operation of the programs? Sometimes grants are available from endowment funds or foundations to help get certain aspects of a program up and running. And there's still, what I didn't mention in the research section is that we need more research done on the services, because while there are 30 or 40 articles that have been published, only about 5 of them have happened in the last 7 years. So if there's partnerships with universities, if there's grants that are available, we see a lot of ARPA related funding, the American Rescue Plan Act post-COVID, that has been funding some of the crisis continuum. Also consider the money that's coming in from certified community behavioral health clinics, or CCBHCs. That can also be helpful, but I'll kick it over to Heather for more ideas.
Yeah, there are some communities that also do a significant amount of fundraising, and that's not the quick or fast answer, right? Sometimes it does take planning and deciding what you want, and then as a community finding ways to fundraise, or finding a philanthropist who believes in your cause and is willing to invest in it. I think it's wild that this is how we're building crisis services, and that's where we're at right now. So getting creative, or finding other people in your community who also believe in this and want to open it as well, and then meeting with them to figure out, okay, how can we raise the fund to at least get the facility and the initial like renovations or whatever that looks like taken care of, and then the billing piece that Travis mentioned can come in after that.
And then I'll say about peer-run respites, these are rarely, if ever, funded by states or by Medicaid. They're most often funded through grants or counties in partnerships, because it's kind of like the Uncola. Do you remember like when 7-Up was doing these advertisements like 20 or 30 years ago? They said we're the Uncola. Like a peer run respite turns a lot of other service types kind of on its head and says, we're not like that. We don't have clinicians, we don't have doctors, we don't have nurses, and we're still going to be helpful. So you might have a hard time finding a licensing arrangement. I know my friend Steve Michio, who operates peer run respites in New York, has sometimes turned to literally the bed and breakfast licensing for the state as the best way to cover it. And Heather kind of used that analogy earlier. But if you want to do something extremely different, it may have to sit outside of Medicaid funding, and it has to have some creative investment from the local communities. I find the communities that are able to make a peer respite work are very progressive. There's not really a question of whether or not these should exist in their community. It's how can we build this really well?
All right. It's a nice little segue because Travis, you were just talking about what this next question is as asking, which is the NIMBY, the not in my backyard issue. So this individual is asking, how do we address that? How do we address NIMBY with neighbors and town mindsets? That's for people who are seeking maybe group homes or some sort of disability in the community. This individual says, I know mental health residential homes get the same pushback here. So how I guess the fundamental idea of the question is they're asking kind of, what can we do as individuals or maybe as organizations in trying to address this issue in regards to the NIMBY issue and the struggle with people's ideas surrounding crisis residential services.
Yeah, I think a lot of community education goes into play here, of kind of demystifying or like busting some myths about what this crisis service is, or sometimes I would hear like about the people that would receive it. The people, they're you and me. They're no different than anyone else in our community. And so really meeting with people and listening to them, and then challenging some of those ideas that they're holding, that somehow this is dangerous or would bring down the neighborhood. That's just not true. And there's plenty of examples across the country to show that that is not the case. Travis, what would you add?
I would add that at the core of the fear or the concern of folks who have NIMBYism is that they want to have good neighbors. They don't want to have concern about the people that live next to them. And the way that you combat that is by being a good neighbor, by demonstrating that you're a good neighbor, or that you will be if you move into the community, and then you live that out every day. I'll give you a quick example. A friend of mine, Shireen Carrico, who operates Peer Run Respites in Charlotte and Raleigh, North Carolina, was talking to her neighbors about the Peer Run Respite building, the home that they purchased. And first of all, they got very involved in their like Neighborhood Action Alliance, and wanted to demonstrate they were good neighbors, hosted a barbecue and invited all the neighbors. And then second, the neighbors said, you know what? before you all moved in here, this was a short-term rental. This was an Airbnb. There was bachelorette parties multiple times per month. There were other like family parties. The cops were here regularly, and it is more calm and predictable here with y'all than it is. And I say y'all because it was North Carolina, so I gotta infuse the y'all. But they're more. It was more predictable and like less chaotic with those folks than it was when it was owned previously. So some of that's obvious, but what are you going to do? What do you do in your own neighborhood to keep peace with your neighbors? You know, do you borrow tools or equipment? Do you bring cookies to people? It's about setting the tone when you move in as well, but understand their fears and sit down with them and be able to tell stories about the importance of these services and what kind of impact they can have. Clearly, they care about their home. I know this is kind of like a weird strengths-based approach to a lot of skepticism and judgment, but they care about their home and they care about their neighborhood. So validate that and say, okay, yeah, you must like it here. I bet there's something that is beneficial that maybe you don't even realize because you're here every day in your home, but there's something therapeutic for you about being in your home. It's safe, you've got access to clean water, it's quiet so you can sleep. Those are the things that people in crisis desire as well. And we're trying to help folks just like you, just like your kids, just like your parents, so they can get back to living the life that they want to live. So I think it takes a lot of patience. It's not just a quick thing. And if the first time you meet these folks is at a town hall meeting, it might be contentious. You might be running into a lot of pushback. You also may be fighting past issues. Maybe there was a home like yours in the neighborhood before and it didn't work out. So what can you do to be different? I think it takes a lot of patience, but at the heart of any good crisis residential program or any good peer respite is a champion, someone who can talk to people, who can build relationships, who understands the model, who knows how to be a leader with their staff. So I will say that it's not easy to do it well, but when it's done well, it is incredible the impact it can have on a community.
Right. There's a question here in regards to limited bed space at crisis res. So with smaller bed quantities per program, are wait times a common issue with crisis residential? And if so, what is best for those clients during that waiting period?
It happens. Yep. There are some times where communities have beds and they end up having wait lists. So that's certainly not everyone's story, but it does happen. In the community I worked in, what we did was we sat with the person and we safety planned with them to see, okay, what resources do you have? Who's in your life that can support you until we can get you in? How do we keep you safe? Because we still want you here. And there were times when that worked well, and there were also times where people said, "Gosh, I wanna go somewhere now." And so that meant looking at other programs in the area or even the hospital. And so it's unfortunate when that situation occurs and folks have to wait, but it can be a reality, especially if you have just a few beds.
Mm-hmm. Planning for the number of beds that you need is really important. And we recommend that if a community is building a new crisis residential program and you have the ability to flex and to possibly have more beds available than you need, that you could start by using, let's say, 4 beds in a 6 bedroom home, but you could eventually use the 5th and 6th ones as you become more well known, or as people start to utilize your services, and then you can change your staffing model to make that happen. But sometimes you have to co-locate services in rural communities where you might have a 23-hour unit or an access center connected to the crisis residential program in the same building, maybe different sides of a house or something like that, so that you can share staff. But it's a good problem if your beds are full. Like let's acknowledge that, and try to build or accommodate so that you can staff up if you need to, and you can meet the needs of your community depending on when the crisis is greatest or when the demand is highest.
All right. There's a last question that is in the queue here is, do either of you have any knowledge on peer-run respites that are designed for accessibility for the disability community who also have co-occurring mental health needs?
Elizabeth, I can tell you that one of the first floor of Promise Resource Network's Peer Respite in Charlotte is ADA accessible. They've got like wide doors for the bathroom and the shower, and that there's rooms on the first floor of that facility as well. It's very common for peer-run respites and crisis residential programs to be co-occurring capable. That one of those things happens in isolation is a belief of the past, and we see that even states like Michigan that have passed legislation in the last 6 years or so, allowing people to hold a mental health treatment license and a substance use treatment license under the same facility to be more and more common. So I would say that is the expectation when it comes to co-occurring. As far as disabilities, some crisis homes or some peer respites have that accessibility built in because it's a ranch house and they've gone through those steps. Others are older and might not have those features.
Mhm. And I would add, Travis, that for the most part, having a co-occurring disability, that's not like an exclusionary criteria. So many of these programs are built in a way to equip anyone that's referred, that's coming to the program. So that I think is more common than you might think.
All right. Those are all the questions that we have posted, you guys. So I want to thank our presenters, Travis and Heather, for presenting on just a fantastic topic and one that's near and dear to my heart. And so I really appreciate you guys' time, and thank you, everyone, for participating. If you needed information on recording, Travis, there was a question earlier about how to receive the recording.
Attendees will receive a copy of the recording and a copy of the slides. So if you registered, we've got your email address. We will send that there. Also, one last advocacy item for Crisis Residential Week, which is that tomorrow we are having an advocacy day. So we're asking everybody to call their health insurance plan, to get out your card from your purse or your wallet or wherever you keep it. Call your health insurance plan, ask them if your behavioral health benefit includes crisis residential services. We're going to create a Google form to capture this information to find out what those answers are. We expect that for folks who have Medicare, commercial health insurance, TRICARE, that the answer unfortunately is going to be no. But we want to know that because we want to collect that data and be able to use that as leverage in conversations about mental health parity. So look for that. We will email this group as well about that advocacy effort.
Yeah, and my last note is if you don't follow us on social media, go ahead and give us a like. We're on LinkedIn, we're on Facebook, and we're on Instagram. All week long, we have had a blast sharing information about crisis residential programs, honoring staff that are working in these programs. They've shared some incredible photos. And then we've also shared this week on LinkedIn specifically a one-page document for how you might go about bringing a crisis residential program to your neighborhood. So check that out. We look forward to connecting with you over there.
All right. I'll throw a pitch in for the conference. The National Crisis Residential or Crisis Con 24 rather is going to be held in Arizona in the week of October 13th through the 17th, 14th through the 17th. So please, if you'd like to attend, Travis put the website into the chat. So please connect there if you need to. It's www.crisiscon.org. So, all right. Thank you both again for your time, and thanks for everyone's participation. What a fantastic webinar. So hope everyone has a fantastic remaining week of Crisis Residential Week. So hope to see you all at the conference.
Thanks, y'all. Cheers.